Let's talk about drugs that work on the sympathetic nervous system. These are primarily our vasopressors and our inotropes. Here's a quick breakdown of our sympathetic nervous system and some of the drugs that work on it. The primary receptors of the sympathetic nervous system are alpha, beta, and dopamine receptors. Those receptors further break down into subunits. Alpha-1 receptors are located in the smooth muscle and generally cause muscle contraction. Stimulation of alpha-1 causes uterine contraction, bronchoconstriction, and vasoconstriction. Beta-1 receptors are located on the heart. Activating beta-1 increases inotropy, chronotropy, as well as dromotropy. Beta-2 receptors are also located in the smooth muscle but cause relaxation, so they have the opposite effect of alpha-1 and cause vasodilation, uterine relaxation, and bronchodilation. Dopamine receptors cause vasodilation in the renal, mesenteric, and cerebral vasculature, but can also stimulate norepinephrine release. In anesthesia, we commonly rely on drugs that affect sympathetic nervous system, especially when it comes to treating hypotension. Intraoperative hypotension comes with a whole host of problems, including postoperative visual loss, acute kidney injury, myocardial injury, and postoperative cognitive dysfunction. Hypotension is caused by two factors: low systemic vascular resistance caused by vasodilation, or insufficient cardiac output caused by inadequate preload, impaired contractility, and decreased heart rate. Many of our vasoactive agents work on several of these receptors and cause a combination of reactions. We can break down the action of these drugs into four categories. Vasoconstrictors exert their effect on the vasculature with no direct effect on the heart. Inoconstrictors have both vasoconstrictor and inotropic effects, therefore they affect both systemic vascular resistance and inotropy. These drugs include norepinephrine, epinephrine, dopamine, and indirectly ephedrine. Inodilators exhibit inotropy as well as cause vasodilation and generally have the greatest influence on cardiac output by reducing systemic vascular resistance and increasing contractility. An example of this is Dobutamine. Vasodilators have no inotropic effect and result in an overall reduction of blood pressure. An example of these are nitroglycerin and nitroprusside and have no role in treating hypotension. Let's take a closer look at each of these categories. The most common vasoconstrictor we use in anesthesia is phenylephrine. Phenylephrine increases systemic vascular resistance by increasing venous and arterial tone. There is also a reflexive reduction in heart rate. Cardiac output is either maintained or reduced. Phenylephrine is often used to combat vasodilation caused by inhalation agents or neuraxial anesthesia, particularly during C-section, where maternal hypotension can cause nausea, vomiting, and fetal acidosis. In obstetrical use, phenylephrine has been associated with less intraoperative nausea and vomiting. However, it has also been associated with higher umbilical artery pH as compared with ephedrine. But this is not shown to translate into lower APGAR scores. Let's move on to inoconstrictors. Inoconstrictors stimulate vasoconstriction and increase myocardial contractility. They both increase cardiac output and systemic vascular resistance. The most commonly used inoconstrictor in anesthesia is ephedrine. Ephedrine increases heart rate, contractility, and systemic vascular resistance, as well as having bronchodilatory effects. Ephedrine has both direct and indirect actions on the sympathetic nervous system and can increase MAC requirements. In obstetrical anesthesia, it is thought to have no impact on placental blood flow. However, there is a greater placental transfer of ephedrine into the fetus compared with phenylephrine. Fetal ephedrine results in beta-adrenergic stimulation and increases metabolic activity. Inodilators increase myocardial contractility while reducing afterload and have the biggest impact on improving cardiac output. However, their tendency to cause hypotension limits their use in anesthesia. They are most useful in treating cardiogenic shock and low output heart failure. Vasopressors and inotropic agents are used frequently in anesthesia. However, their use is usually limited to a few necessary boluses or a short infusion, and most patients are weaned off by the end of surgery. It is important to remember that prolonged vasoconstriction can lead to tissue ischemia in the skin, kidneys, heart, and gut, and particularly in hypovolemic patients. Beta stimulation increases myocardial oxygen demands and predisposes the patient to tachydysrhythmias. Another group of drugs that work on the sympathetic nervous system are bronchodilators. Bronchodilators are the mainstay of treatment for COPD and asthma, and the most commonly used bronchodilator for acute symptoms is the beta-2 agonist albuterol. Recall that beta-2 relaxes smooth muscle. Albuterol works primarily on the lungs, but can also cause some vasodilation. At higher doses, these drugs can affect beta-1 receptors and cause tachycardias and dysrhythmias. It is also important to note that excessive use could lead to hypokalemia. Inhaled anticholinergics are also used to treat acute symptoms of asthma or COPD. The most common short-acting agent is ipratropium. There's also a group of long-acting anticholinergics that are used for long-term control. The most common one is tiotropium, commonly known as Spiriva. Their anti-muscarinic properties work to block vagus-mediated bronchoconstriction. For the most part, these drugs exert their function right on the lung with minimal systemic effects. Although there is some thought that urinary retention may be an issue, especially in patients with benign prostatic hypertrophy.